This 40-year-old woman was transferred to us after a several-week hospitalization for acute pancreatitis resulting from alcohol abuse. The patient is otherwise healthy. CT scans have shown an evolving pseudocyst, which has progressed over 1 month and is now mature. She has been unable to eat because of recurrent pain with each refeeding and has been on TPN. Endoscopic transgastric pseudocyst drainage was planned. EUS showed a limited debris and a clear window for access, but only between the very distal antrum and the pseudocyst. Here a therapeutic ERCP scope is positioned as far distally in the antrum as possible, and fluoroscopy used to help target the appropriate puncture site. A triple lumen micro-knife needle knife is preloaded with an 035 guide wire in contrast. Here you see in slow motion the retracted needle knife probing into the bulging antrum towards the cyst. When satisfied with the direction, the needle knife is extended and a brief tap on the cautery pops the needle knife through the wall into the cyst. There's puncture without any cutting motion. Now we're going to look at that same event in slow motion fluoroscopically. You see the needle knife extending and popping into the cyst cavity. Now again in real time, you see the needle knife popping through the cyst wall and the guide wire coiled up into the pseudocyst cavity. We usually pass several loops of wire into the cavity. Then the needle knife is removed over the wire and a 10 millimeter rapid exchange dilating balloon passed in, and the cyst gastrostomy tract is dilated fully to 10 millimeters. Look at the debris that drains out after the balloon is deflated, including a few small chunks of debris. We're now passing the Oasis type introducer catheter and placing a 10 French 3 centimeter Solus double pigtail biliary type stent in the pseudocyst cavity, now again fluoroscopically. We prefer these soft type of stents over hard traditional polyethylene stents because of less concern of erosion into the back wall of the cyst. Here is the second stent going in, and we always place 2 stents to keep the tract open. The patient did well, tolerating a diet for the first time in several weeks and was discharged 2 days later. She returned to full-time employment. At 1 month follow-up, CT shows incomplete resolution of the cyst despite the stent still in place. Secretin MRCP shows the residual cyst cavity, which you can see here filled with debris, and notably a disconnected pancreatic duct syndrome with a gap in the main pancreatic duct where pancreatic necrosis had occurred. ERCP is performed with a pancreatogram showing the pancreatic duct ending at the level of the transgastric stents. To try to reconnect this duct stump to the cyst cavity and hopefully then to the duct in the tail, the wire is popped through the end of the pancreatic duct into the cyst cavity, and a single 5 French stent is placed through the stump of the duct into the cyst cavity. Notice the drainage of cloudy pancreatic juice, and here seen fluoroscopically deploying the stent through the stump into the cyst cavity. Then we enter the cyst gastrostomy tract beside the 10 French stents placed a month ago and lavage the cyst cavity, and you can see some rather nasty looking solid debris. We then remove these stents, redilate the cyst gastrostomy, and place 2 new double pigtail stents. Also we're placing a nasocystic drain into the cavity and reposition it out the nose, and this is in order to vigorously lavage the cavity for a couple of days with saline. Then the patient's discharged and the nasocystic drain removed. 1 month later, after full-time employment is resumed, the patient is actually doing very well, and you can see that the cyst cavity has completely resolved. At the final procedure, all stents are removed, And you can see that at pancreatogram, the stump of the pancreatic duct ends and just fills the collapsed cavity where the cyst used to be. Then injecting through the cyst gastrostomy tract, we're again filling that cavity. No filling of the head, but we are filling a bit of duct in the tail of the pancreas. So this patient has a kind of partially disconnected pancreatic duct syndrome where the tail drains into the collapsed cavity, which then connects somehow to the head. The patient was discharged the same day as that procedure, has done very well since, but the presence of this partially disconnected pancreatic duct may predict a higher rate of recurrence of the pseudocyst over the long term.